Hello, and welcome to JAT Chat, presented by the Journal of Athletic Training, the official journal of the National Athletic Trainers Association. I'm Dr. Kara Radzak, an assistant professor at the University of Nevada, Las Vegas, and we're all coming to you from our homes. So right now, there could be interruptions due to children, animals, pets, or the neighbors. So please take that into consideration. The purpose of today's event is to provide an open forum for athletic trainers and other healthcare professionals to learn a little bit more about the recently published consensus statement and companion manuscript regarding best practices for pre-hospital care of the injured athlete with a suspected catastrophic cervical spine injury. Today, I'm joined by a few of the manuscript's authors, Mr. Ron Courson, Dr. Brianna Mills, Dr. Jim Ellis, and Dr. Stanley Herring. Thank you all so much for joining me today. At this point, I would like to introduce Ron, Jim, Stan, and Brianna, and give us a little bit of introduction of what your current position is and what your role on these manuscripts was. Ron, let's start with you.
Thanks, Kara. I currently serve as Director of Sports Medicine at the University of Georgia. I've been here the past 25 years, and I served as co-chair with the Spine Injury Support Group along with Jim and Stan.
Jim, tell us some more about yourself.
Yes, thank you, Kara. I also was a co-chair, like Ron said, with Ron and Stan. I'm an emergency physician by training. I work clinically in Greenville, South Carolina, and I have a long affiliation as an emergency physician, the emergency care of the athlete, former team physician with the Atlanta Falcons, and was recently asked to be the emergency preparedness consultant to the National Football League.
Thank you. Now let's move to the West Coast. Tell us more about yourself, Stan and Brianna.
I'll go first. Age before knowledge. Let's do it that way. I am a clinical professor at the University of Washington, and along with Jim and Ron, I had the privilege of being part of the coordinating group for these efforts. I'm a physiatrist by training, have a particular interest in spine injury and concussion. I'm one of the team physicians for the Seahawks and the Mariners. I'm a co-founder of the Sports Institute at UW Medicine and spend quite a bit of my time taking care of athletes with suspected spine injury.
Thank you.
Hi. It's hard to go after Stan sometimes. I am a research scientist at the Harborview Injury Prevention and Research Center here at University of Washington and a clinical assistant professor in the Department of Epidemiology. I led the systematic review that formed sort of the evidence base for the consensus statement. And I'm first author on the consensus statement, which means I got to incorporate all of the lovely opinions of my 23 co-authors into what I hope is a cohesive document.
I can confirm with you, it is a very cohesive document. This was, it is chocked full with wonderful information, these two manuscripts that are going to be very, very valuable to all the clinicians out there. And thank you guys all so much for taking the time to talk with me today. Brianna, can you give us a little bbit more information on the process of how the consensus statement came together?
Sure. It was a labor of, we'll call it love. We started off with a nominal group technique, which incorporates what we commonly call the Delphi method. We spent several months working with the participants in the spine injury and sport group to really figure out what questions people wanted to answer and, exactly how we were going to start answering those questions. And we turned that into the systematic review criteria. And then my team and myself screened 1,500 scientific titles, reviewed 800 abstracts, and summarized the results of just about 50 full-text studies into the systematic review, which we then took with us to a 2-day meeting where we locked ourselves in a room for 2 days and came out with the consensus conclusions and recommendations that are in the document. No blood was spilled.
That's good to hear. So, will one of you guys tell us a little bit more about the spine injury and sport group? One of the things that was mentioned in the consensus statement was that it was formed after the 2015 Inter-Association Task Force on Prehospital Care for the Sports Injured Spine Athlete. How did this, tell us more about this group and how it played a role in the consensus statement?
Well, how we started out in 2015, we put together the consensus statement group, and we had actually 14 different governing bodies involved in that. And we worked really hard for 2 years, but unfortunately, we could not reach a consensus, which happens sometimes in a very complex situation. And throughout the time, there's some fundamental changes in the EMS care as well related to spine. So we decided to start over and take a different tack. And rather than trying to get professional organizations involved, we tried to get the most qualified people we could. So we selected 25 people in a wide variety of specialties, from researchers to various physician specialties to paramedics to athlete trainers. And we had over 200 years of clinical experience in that group of 25 people. And we decided, let's try to take more of a systematic look with the Delphi process. And one of the things we rapidly found out too was we want to try to make it evidence-based, but there's some areas we just don't have enough scientific research. So we decided to write actually 2 papers, one the Delphi study, evidence-based, and then the best practice more from a healthcare options concept.
Great, thank you. So please provide a little bit more of what was your goal of this project, and who's your intended audience for these 2 manuscripts?
Yeah, I'll take the first stab at that if I can. The goal was to look at what the research really showed. I think in the past, a lot of people were working off of certain assumptions that they may have had passed down over the years, and a lot of thought around what was the appropriate care to spine injured athlete. But we really wanted to look at what was out there in the literature, what wasn't out there in the literature, and come up with a consensus document that was really, really proven within the literature, which was the beautiful thing about the Delphi process. And the group that Ron and Stan and I put together was specifically related to making sure that we had physicians, which included team physicians, orthopedic surgeons, physiatrists like Stan, emergency physicians like myself, and just physicians that were going to be around these athletes, neurosurgeons, and then also athletic trainers that had been functioning at a very high level, but also some athletic trainers that were maybe at the high school level that could understand what that looked like. And then, of course, having EMS and paramedics involved was critical. So we just knew that the scope was not just the care team for the athlete on the field of play or at practice, but it was also going into the emergency department and possibly going into surgery for a spine case that needs to go to the OR. So that was the broad group that we put together. And it was interesting, like Brianna said, to get all those people in the room. And I kind of volunteered to Ron and Stan to get up there at the very beginning and read them the Riot Act and said, you need to check your ego at the door because we need to come out with consensus at this. And it was difficult, but it was an amazing experience. And I thank everyone on this group for making that happen.
Thank you. One of the things that's really, I found unique about this consensus statement is you kind of went and identified some questions and then really dug into the research and using the questions to base the consensus statement off of. Give us a little bit more background for those viewers that might not have read the manuscript yet. What were some of your questions that you were asking?
I think Brianna should be the one to answer that, since she's the one who challenged us to find the questions.
Yes, and how was that developed? Yeah.
Right, to set the stage for her, part of the Delphi process involved taking your potential group of writers and querying them about areas they think is important, that they think are important, and trying to develop questions around that may be answered by comprehensive and systematic review. Brianna, did I get that close to being correct?
Yes, you did. So, we were brought in, my team at the Injury Center were brought in really to help figure out how to get people to agree. And we started really with, all right, the best way to get people to agree is to start with things that they already agree on. And for us, that meant before we can figure out what the answers are, we have to agree on what the questions are. Mm-hmm. And so we started just with asking people, what are the questions that are important to you? And the answers we got back, we sort of read through and refined and sent them back out and said, okay, here's what we're hearing. These are the questions, do these make sense to you? Does the wording make sense? And how broadly should we be asking these questions? Because, people had some great questions, but we really needed to focus on a population and talk about how we were going to define the group of athletes that we wanted to talk about. And that was kind of the foundation of the review, was agreeing, okay, it's not necessarily just football, and it's not all sports that have ever been played, because, you'd be surprised, but there's a couple articles out there about surfing related injuries. Yep. So we focused really on, catastrophic cervical spine injuries that involved shoulder pads and face masks and helmets. And once we got people sort of to agree on the topic we were talking about, it's a lot easier then to have a conversation and know that what I think I'm saying to you and what you're saying to me, we're actually talking about the same idea.
Great. Thank you. And one of the things that I noticed was that you guys did a really good job of breaking apart the differences between sports that were equipment intensive. So what were some of the sport-specific considerations that need to be made regarding equipment and equipment removal that you reached a consensus on?
That's a great point. One of the things we try to do with equipment removal is recognize that there's different variables. And we all know it has to be removed at some point, but there's differences on when it has to be removed. Mm-hmm. It can very easily be removed in the ED, as it has been in the past. It can be removed on the field of play. And a lot of it's based on the individual scenarios in that situation. For example, if you have somebody respiratory compromise or cardiac arrest, obviously the equipment has to be removed immediately so you can administer life support measures. But one of the biggest things we want to emphasize is, knowing that it has to be removed, what the best techniques to do with that, and then how can we educate everybody across the board. Many times athletic trainers are most familiar with equipment, but they may not be in the emergency room with people who aren't very familiar with it. So what's the best way to try to teach them? So we try to make it more healthcare options, and again, recognize there's more than one way to skin a cat. So come up with different scenarios, and based on the circumstance you have with that athlete, you can make the decision where the best way to remove it is.
Cara, I think that part of the process and part of the Delphi process does not allow the loudest voice to win. So people were able to express their ideas in an anonymous fashion, and ideas could be brought forward. And I think that we learned a few things. I think we learned that there's more than one right answer. Mm-hmm. I think the most valuable thing for me from this was we need to understand that medical status of the athlete, the type of equipment and resources available on the field as well as in the emergency room all dictate what may be the best for that athlete. And that changes in each circumstance, which really speaks to the critical importance of the emergency medical action plan and the medical timeout before the game. That was a real win for this group. I think it's a win for those who look at this paper. The key here, and I think everyone, all 25 authors were clearly motivated to do what's best for the athlete. And what this group realized was that there are different equipment removal techniques, different transfer techniques, and when and how and where those are to be done really depends upon the details of the circumstance particular to that injury. Mm-hmm. If you use that as a foundation, then it does set the stage for further research. And I think this was really consensus building at its very best, and I think that's what came through loud and clear in this effort.
Thank you. And Stan, you touched on the medical timeout. Can you give us a little bit, and can all of you guys give us a little bit more information on what kind of constitutes best practices for that medical timeout, developing that?
Yeah, I'll Stan, go ahead, and then I'll follow up.
No, why don't you go ahead and we'll do it correctly.
No, it's just it's always been one of the things that I'm focused on, and it's just a critical component because I think we've discussed it, before games, but do you do it before practice? And if you look at a number of incidences over the last few years, not just with spine injury, but probably most importantly with spine injury, having that medical timeout before a game, before practice, you talk about the different conditions, what's changed. Different personnel may be there than were there yesterday. If someone's out, if someone's sick, if you're, on a college campus, have they closed down a road, and so the best way to get EMS in or EMS out, particularly for a spine injured athlete, when the timing is so critical for them to get to the correct, appropriate facility, a level 1, level 2 trauma center that can handle that spine injured patient. It's just critical to have the medical timeout before any event. We practice all the time. We have games relatively infrequently for most sports, certainly for football. And so we just thought it was a critical thing to stress that medical timeout, have the discussion of how someone will be packaged, how someone will be taken care of, how they will be immobilized, and then where will they end up, again, particularly going to level 1 or level 2 trauma center that can handle, if appropriate and if available, to a patient that can get them to the OR as quickly as possible if they have a surgical spine injury that requires operative repair. So we just thought that was critical in the whole process.
Thank you, Jim. And who do you guys recommend being involved in this medical timeout? You mentioned a few people, but who, as athletic trainers and medical professionals who are probably in the process of reevaluating what they're going to do going into the start of sports again, who should they be considering being in those medical timeouts?
Yeah, I mean, it really depends on the situation. If you look at a professional or a Division I college football game, there are a lot of personnel there. So you're going to have your athletic trainers, you're going to have your team physicians, you'll have EMS. So anyone, that is the group that encircles the athlete and is part of the entire team. If it's at a high school practice, and there's a single athletic trainer there, I mean, they may need to have the medical timeout with a head coach, or they may need to have the medical timeout with someone else that's there that will be their workforce. How are we going to initiate a call to 911? Not just for a C-spine injured athlete, but who's going to get the AED if I'm the only athletic trainer on the field of play and I didn't bring it out when I came out? So we just think the medical timeout is with whoever the workforce is to take care of an athlete at a game or at a practice, but everyone that is surrounding the athlete at that time, which can be coaches at certain levels.
One point too, Kara, if you're in a competition, try to involve the officials as well, just from a scene control standpoint. If you have a event on the field of play, keeping the athletes back in the box will clear the area for the EMS and the athlete trainers to work. So I think involving the officials as well.
And, Cara, this is a witnessed event with a potentially catastrophic outcome. And so anyone who's going to be involved in any fashion needs to be part of this medical timeout, and roles and responsibilities need to be clearly defined. It is not time when you are hovering over the athlete with the visiting team to ask who's in charge of the rescue or what equipment that they have. And talking about it's one thing, and one thing that we've learned from Jim and Ron is that this is really the implementation of a well-rehearsed and well-practiced EAP.
You're setting me up perfectly. Let's go into practicing. Let's go into training. What do you guys recommend? What consensus was reached on how often, how training should be done?
Let me brag on my two co-directors here. I mean, this is obviously Ron's last work, and Jim is responsible for setting up EAPs for the last 20 plus Super Bowls and a variety of other potential mass casualty events. I think the best practices paper, the companion paper to the evidence-based piece that Brianna shared, touches on it a bit. I mean, it is clear that emergency action plans need to be written, venue-specific, rehearsed, and practiced in real time. Hopefully that serves as a springboard for healthcare teams to practice EAPs when things go wrong. So practice for complications, practice in different environments, different locations on the field. It's a perishable skill. And one fertile area, I think, that this work has demonstrated, it would be very interesting for further research to look and see what is retention among participants, how well is that knowledge maintained, and what is execution skill, and what is transfer skill. There's a lot here. What's the best method of conveying that information? Hopefully this type of work will encourage people to think about research opportunities. This would be on the educational and execution side. There's a lot of work here that can be made to maximize the effectiveness. And all of us, any of us who have been involved in this, it's never what you think it's going to be. Mm-hmm. And the more you practice and the more scenarios you practice, and as Ron likes to say, calm is contagious. This is such a critically important part of this for a witnessed rescue.
I think Stan raised a great point, is making your EAP your rehearsal scenario based. So try to simulate what can't go wrong. For example, practicing in a confined space environment where maybe you have an athlete up against a wall where it may modify your technique, or what's going to happen if they go into cardiac arrest in the middle of the mobilization procedure. So try to think about what's the worst thing that can happen and work those scenarios. If you can work through that, then you're ready to go.
Thank you. Any other suggestions on developing, or as people are reassessing their EAPs right now, things to look at?
Yeah, I think that, we talked about before, all the changes. And we do think anytime you write a consensus paper, you're making sure that you look at history and what's been done. If there are any changes, then people need to rehearse that. If you've never removed equipment on the field of play before, that's not the first time to do it. It has to be when you practice it in the preseason. And that's why we've always been big advocates of scenario-based training, not just talking about it, but actually doing it and practicing it. And it's always been annually. And we had some discussions around, should there, be a recommendation to it semi-annually? I think it should be annually, but also if you have a need to update. Just say you've changed your training staff, your medical staff, or you've got a different EMS crew, or whatever it may be, then it may be at least annually, but more often if things dictate. And, I think particularly with the COVID world going on right now, again, not within the auspices of this paper, but I think all of us that are involved in football are, right now just particularly worried about the deconditioned athlete. Again, not within the scope of what we're talking about here, but that's another reason to focus that coming into training camp for a lot of teams that are going to be, hitting the, field in the next few weeks. I just think that'll be a huge thing. And again, all part of the EAP.
Mm-hmm.
Jim raised a great point too, involving EMS. I think as athlete trainers, typically write the emergency action plan, make sure EMS is involved. The first call we're going to make is the 911. So it makes sense to make sure they're involved in the components of the plan, and also know what the local protocols are. There's some variability in different types of equipment that ambulance may carry, and variability in protocols. So making sure that your protocol matches theirs. So again, you don't get to an emergency situation, you have a conflict on the field of play, you worked out in advance.
And Kari, everybody has a camera phone, so record it, do it in real time, and play it back and watch it. Don't just assume that you know each step. Go through a scenario in real time, all the steps, and then play it back and see where there may be an opportunity for improvement.
Wonderful suggestions. Thank you guys so much. Another thing that came out with the consensus statement that was kind of not really surprising, but again, it was also surprising, is that some of your questions ranged from only having 9 articles to help support the evidence to having 0. So can you give us a little bit of background on areas that in the author's opinions were really, they're under-evaluated? And you kind of touched on that a little bit earlier, Stan, but what areas need to be looked into and researched more?
Dr. Mills, where did you find nothing for us to review?
Yeah.
Well, I mean, not every question is going to have a scientific study answer. That's part of the reason why we did the Delphi, is so that we could draw on the information and the expertise and the experience, of the spine injury and sport group. But having said that, I wouldn't be a very good scientist if I told you that we were done asking questions, that we had found all the information that we needed to find on, almost any topic. So I think there's a couple key areas that I was surprised we didn't find as much. Certainly we tried to make this about equipment intensive sports, and the majority of what we found was about American tackle football. And how well that relates to ice hockey or lacrosse or other sports, I would guess, we need to do more work there. I think the other real key area is that, athletes come in all shapes and sizes and ages. And a lot of what we found was based on, college-aged male football players. How things need to change when you're dealing with younger athletes, female athletes. That's really an open question, but there's a lot of work to be done. So if anything, it's just, let's put some money into it. And I think we can find some answers.
Thank you. Anything that you guys found interesting that you would like to see more research on? You already mentioned, Stan, the evaluating the training and retention.
And there's, to echo what Brianna was saying, nothing runs enthusiasm like further follow-up. We think we know what we're doing, right? Until someone like Brianna comes and actually questions us about it and shows us that there's not a lot of data. Now, listen, evidence-based medicine is really the integration of clinical experience and research. So the clinical experience in this space is incredibly important. Mm-hmm. There is no substitute for the number of years that Ron has been on the football field. No substitute for that. So you have to respect that. But then, we really don't know how much motion is clinically relevant with different transfer techniques. We don't really know how much you can put axial traction on a cervical spine and straighten out a head on the neck if necessary. We sort of do those things, but we don't know them. So given technological advancements, with sensors and other simulation technology, those things can probably be better studied. We can recruit colleagues who often are not in this space, biomedical engineers and others, to work with this. So I think there's a lot of the technical aspects of the transfer that can be improved upon with bench work. But to reiterate, I think there's still a lot of work to do to see how effective we can teach and maintain the medical timeout and the implementation of the EAP. And that's low-hanging fruit, but critically important.
Yeah, I'd agree. It was kind of a difficult thing, particularly when we got the first group together, because we were focusing a lot on spinal motion restriction. And all the studies you're dealing with are cadaver studies, and you go in and you cut the anterior longitudinal ligament and just try to give a guess as to what happens. And it's just not a great comparison, but it's the best that we had at the time. So there was a reason why we didn't get into it. And everyone knows that the more you restrict the motion, the better, the safer. But there are no studies to say if you do this, then this will be the effect of that. And that's just the difficulty with the whole thing. And what's the best technique? There just haven't been that many outcomes that you can study and look at and say, oh, why did this happen? Because this was done. So.
Thank you guys so much. Now, as we start wrapping up, I do want to talk about those athletic trainers that might not be in a Division I setting. What are some good takeaway messages for that secondary school athletic trainer that's the sole athletic trainer at their high school and potentially at even a sporting event? What recommendations do you really feel like could help them?
That's a great point. That was one of the things we tried to make this as well as we could to address options. Because, my scenario where I'm at University of Georgia, or where Stan may be at the Seattle Seahawks, is much different than a high school athletic trainer. If you're the only athletic trainer there, it may be that you're not going to try to do any immobilization techniques on a spinal motion restriction until the paramedics get there. You're going to work together with them. The same thing, you're probably going to try to move equipment on the field of play because you don't have the number of properly trained personnel. So, finding out what you can do in that situation. And the most important thing is to prevent further harm. So immobilize them, package them appropriately, and then transport to the ED. But knowing that, the equipment has to come off at some point, so communicating with your local ED. And it may be that you do a training and service with your emergency department if you know that you're going to transport with that athlete. So train them to help you do that on the field of play. Making sure if you're the only one there, what are my other options? I may have a high school athletic training student. I may have some coaches that I can train to help. And again, not trying to make them emergency personnel, but, for example, helping with the 911 call, retrieving the equipment, various things they can do in a safe manner and simply take some education and training. So try to anticipate the scenarios you're going to have and what can you do on the advanced end to try to, train your personnel to help with that.
Yeah, I think that's one of the reasons why, too, we pulled together the companion video. And again, thanks to Stan and Brianna and everyone at the University of Washington for helping us out with that. So, we tried as best we could demonstrate some techniques that required fewer people. And having been on the field of play and covered a high school football game where there was a spine-injured athlete, and it was myself and one athletic trainer, we were fortunate that we did have EMS there. But that was not the exact crew that we had practiced EMS with in the preseason. So we didn't really know what they knew. We'd also had recruited some coaches, and so we had pre-planned for coaches to be some of the workforce and the lifting help. So again, in those situations, you've got to use who you use. I mean, I was, in the community enough where I knew where the doctors and nurses were in the stands if we needed other people. But again, you've got to use your resources well, particularly if you're that solo athletic trainer. It puts you in a tough spot if you don't know who your resources are.
Carl, we hope that the two papers and the companion video give this potential injury the gravity that it deserves. So if you are an athletic trainer in high school, you can take these materials and say, look, this is the highest level of scientific reviews. This is systematic review combined with a practical piece in a video, because this is really important. And if I am your athletic trainer at your high school, we need to get this right. And we have to practice this. And this is an introduction to developing an EAP, saying, 25 experts from all different disciplines got together and used scientific rigor. And this is important. And the NATA thinks this is important. And every organization that Jim and I and Ron belong to, it's a sports medicine organization, thinks that this is important. So I hope that it allows some weight to this so that the athletic trainer has a resource to take to a school to help implement policy.
Thank you all. And you guys brought up that there's other resources, that it's not just these two manuscripts, that there's the appendices and there's videos. It's a really rich database for people to utilize. And at this point in time, as we're starting to wrap up, Brianna, can you give us a little bit more background on what was your takeaway from working with all of these wonderful individuals and having to navigate all of the personalities?
It's been a real pleasure. And I say that not just because it's the politically correct answer, but because, they've been working on this for decades. And so has everyone else in that room. They had so many types of expertise and experience that my team just came in, and we are trying to be the objective, neutral third party saying, here's what the science says. And they put a lot of trust in us and gave very generously of their time. And often, I hope it was a positive experience, because it was a very welcoming one for the injury center.
You made us better.
Yeah, I'll echo all that. And again, having never been through the process like that, some of it was respect the process, because those of us that didn't know anything about it, we kind of had to respect the process. But it really also came down to an extent to respecting the people, because Brianna and her team had been through this before and done this so often before. I think it engendered a lot of confidence from the rest of us. Wow, they really know what they're doing. And even though there were times when she was kind of pushing us, It was incredibly well received and very thoughtful, and her expertise just really carried the day, honestly.
Thank you.
And I would be completely amiss to not ask the three of y'all, give us a clinical pearl. It could be about this, it could be about clinical life in general, just a clinical pearl that all of those, especially young professionals out there, would really appreciate hearing.
I think one thing that came out of this is the importance of having a C-spine protocol. This was a common aspect with concussions a few years ago, and having everybody actually write a protocol you agree on. And, with such an injury of this magnitude, get everybody on the same page with your EMS, with your pain physician, and with your neurosurgeon or orthopedic, writing a protocol before it happens. Because, again, there's more than one way to do it. There's not one way. There's more than one right way. So deciding among your team what you want to do beforehand can solve a lot of problems down the road. So I think it's really important to emphasize writing a C-spine protocol. And that's one of the things we try to do, too, with the links is we have some examples of C-spine protocols, emergency action plans, and medical timeouts. So you don't have to reinvent the wheel. You can take a template and modify it to your needs.
Thank you, Ron. Jim?
Yeah, for me, Stan is very kind, and he talked about it being mine and Ron's life work. And I appreciate that. The entire emergency action planning process, would also be included. I feel like at least something I've tried to contribute to. And I've been giving lectures for 25 years on the EAP process and everything else. And I've had a number of cases that I've either been involved with or reviewed or taken a look at. And just if there were missteps along the way, it tended to be you didn't plan for worst case scenario. And one of the beautiful things about this process, it just really shines the light on how important it is to have a very specific process. Could be a number of different protocols, could be a number of different scenarios that they're utilizing to take care of a spine injured athlete, but to make sure you know how to properly take care of them and get them to the nearest appropriate facility that can take care of that injury and give them the best chance, A, for survival, and B, hopefully to walk again. And that doesn't happen every single time, but the sooner they can get to the appropriate facility, the sooner they can go to the OR if they need to go to the OR. It's just such a critical component. And this process really, was allowed us to emphasize that and practice, what we've all heard about EAPs forever, practice.
Cara, having done this for almost 4 decades now.
You're dating yourself, man.
I am. It was just the first 100 years that were the hardest. I was stunned at how much I learned about equipment removal from Ron and Jim, particularly from Ron. Techniques we thought were just written in stone. Ron came and knocked the rock over. And so even this video taught us to be better at equipment removal. That's one direct thing I learned after all this time from this process. And the second clinical pearl, I guess, is you should be careful about making policy based on things that you think are right versus what you know is right. That's my clinical pearl.
Wow.
That's powerful. Thank you so much, you guys. It was a pleasure talking with you guys. There was a lot of brain power on this JAT chat, and I really appreciate you taking your time. Everybody who is listening, this is a wonderful piece and companion piece, and there's so much great information that you guys have generously supplied in the supplementals. So, and this is all available free of charge thanks to the National Athletic Trainers Association. So please go out there and utilize this wonderful resource. Again, thank you so much for joining me today, Ron, Brianna, Jim, and Stan. I greatly appreciate your efforts on this project, and thank you for talking with me.
Thank you.
Yeah, thanks for having me.